You look down at your foot. There is a small spot on the side of your toe that should have closed weeks ago. You have changed the dressing. You have done everything the nurse said, and it is still there. In diabetic skin, that thought, "It will heal eventually," is the single most dangerous sentence a person over 60 can say to themselves. Because in too many cases, eventually never comes. There is a new continuous oxygen gel that has stopped cardiologists, podiatrists, and wound care specialists in their tracks. Almost no one in the patient world has heard of it yet. By the end of this video, you will know exactly what this gel is, exactly which patients it has been helping the most, and exactly which sentence to ask your doctor, most of whom have not been told about it yet. I am Dr. Richard James. I have spent more than 3 decades helping older adults navigate diabetes. I have watched too many small wounds turn into surgeries that nobody wanted. In the next few minutes, I am going to walk you through why these wounds heal so slowly in the first place, why the standard treatments hit a wall, and the new continuous oxygen gel that is closing diabetic ulcers faster than almost any wound care option we have had in 20 years. A diabetic foot ulcer in someone over 60 has, until very recently, been managed with the same essential toolkit for 2 decades. Aggressive debridement, advanced dressings, offloading boots, antibiotics, hyperbaric oxygen if available, and, when those fail, surgery. The amputation risk attached to a non-healing diabetic foot wound is the highest of any chronic wound type we treat. Roughly 1 in 5 patients with a non-healing diabetic foot ulcer will face a major amputation within the next 5 years. That number has not improved meaningfully in 20 years, until now. A new generation of continuous topical oxygen therapy, delivered through a wearable, gel-based system, has produced strikingly faster healing and complete closure rates in late-stage trials. The reason it works is simple and almost embarrassing in how late we have been to act on it. Diabetic skin does not lack effort. It does not lack desire to heal. It lacks oxygen. This is not a normal scrape. By the time you notice it is not closing, the underlying microvascular disease has already been silently weakening that skin for years. As we walk through why every standard treatment hits a wall, you are going to keep hearing the same word: oxygen. I will explain why every other option has only been able to deliver it for a few hours at a time. The gel changes that single variable. It delivers oxygen continuously, around the clock, on the wound, in the comfort of your own home. Let me give you a profile that walks the next 18 minutes with us. Imagine a patient I will call Francis, the kind of profile we see in clinic every week. Francis is 72, retired postal worker, lives in Tampa, widowed, 3 children, 5 grandchildren. Francis came in last spring with a wound on the side of her right foot that had been open for almost 6 months. She had done everything right: the dressings, the offloading boot, the antibiotics. The wound just would not close. We added continuous oxygen gel to her existing care plan. Within weeks, the wound was 1/3 of its original size. She still has both feet. Now, before we get to the reveal, you need to understand exactly what makes a slow-healing wound dangerous in the first place. This is the part most patients are never walked through. In healthy skin, when you cut yourself, blood flow surges to the area. Inflammatory cells arrive. Then fibroblasts, then new blood vessels, then a scar. The whole sequence runs on local oxygen tension. It runs on the ability of tiny capillaries to deliver enough oxygen to keep cells alive while they rebuild the tissue. In diabetic skin after 60, every step of that sequence is slower. The capillaries that should deliver oxygen are narrower and stiffer. The signals that tell the body to send fibroblasts are blunted by chronic high blood sugar. The bacteria that arrive on day 1 have a much easier time, because the immune cells that should fight them are also short on oxygen. The wound that, in a healthy 30-year-old, would close in 5 days, can sit open for 5 months in a 72-year-old with diabetes. Now think about what that open wound is in terms of risk. It is a doorway. It is a doorway for bacteria to walk into the deeper tissues. It is a doorway for an infection to reach the bone. It is a doorway for a bone infection, called osteomyelitis, to start a conversation about amputation. None of those steps are inevitable. Every single one of them becomes more likely the longer the wound stays open. Some of you are listening to this and quietly running through every wound you have had in the last 5 years. The cut on the shin from a kitchen cabinet last summer that took 2 months to close. The scrape on the knuckle from a fall in November that ended up scarring more than it should. The pressure spot on the heel that healed, then opened, then healed again. None of those moments are dramatic on their own. Each of them is data about how your skin is currently delivering oxygen to itself. Adding them up gives you a picture nobody has been showing you in routine appointments. There is also the concept of wound age that most patients have never heard. Once a wound has been open for more than 4 weeks, it crosses an invisible line. Above that line, the chemistry inside the wound bed itself shifts. Inflammatory signals get stuck in the on position. The cells that should be rebuilding tissue spend their energy fighting low-grade infection instead. The wound stops being a fresh injury and starts being what specialists call a chronic wound. Chronic wounds do not heal on their original biology. They need an outside intervention to break the cycle. That is why the question you should be asking is not, is it healing? The question is it healing fast enough? If a diabetic foot wound has not visibly shrunk in 4 weeks, that is the moment to escalate, not the moment to wait another month and see. Now, here is where it gets really interesting. Why has every standard treatment we have used for 20 years been hitting the same wall? The wall is oxygen. Almost every standard treatment in diabetic wound care addresses something other than the local oxygen deficit. Debridement removes dead tissue. That helps. Advanced dressings keep the wound moist and protected. That helps. Antibiotics fight infection. That helps. Offloading takes pressure off the area. That helps. But none of these add oxygen to a tissue that is starving for it. They simply remove the things that are making the starvation worse. The one option that did add oxygen, hyperbaric oxygen therapy in a chamber, is genuinely effective. The problem is the dose schedule. A patient sits in the chamber for 90 minutes, breathes pure oxygen, then leaves. The oxygen surge in the wound lasts a few hours, then fades. The next session is 24 hours later. Healing happens in pulses, not in continuous improvement. And many patients cannot get to a hyperbaric chamber 5 days a week for 8 weeks. Insurance coverage is variable. Travel is brutal for someone over 60 with limited mobility. The therapy works in trials. It often does not work in real life because patients cannot finish the schedule. That is the entire reason continuous topical oxygen gel changed the conversation. Instead of a 90-minute pulse 5 times a week, the wound gets a steady, continuous oxygen supply 24 hours a day. The cells doing the rebuilding never run out of fuel. Healing changes from a series of pulses to a steady curve. Now this is the moment I have been building toward, the reveal. Sign in close, because the next part is the part most cardiologists, most podiatrists, and most wound care nurses are still being introduced to. Continuous topical oxygen therapy is delivered through a small, lightweight, wearable device that sits on the patient's leg or waist. A thin tube carries oxygen down to a sealed dressing over the wound. Inside that dressing, a controlled flow of oxygen is delivered continuously to the tissue underneath. The patient walks around, sleeps, bathes within reason, lives a normal life. The wound, for the first time in months, is bathed in oxygen 24 hours a day. The published trials over the last 5 years have shown closure rates significantly higher than the standard of care alone, with shorter time to wound closure in a meaningful share of treated patients. The exact numbers vary by trial, by wound depth, and by patient population, but the direction of the data is consistent. When you add continuous oxygen to existing standard care, more wounds close, and they close faster. The wound does not always close in days. It does not always close completely. The headline this video carries, "Doctors are shocked," reflects the speed and consistency of the response in the trials, not a guaranteed result for every patient. But for many patients who have been stuck on the same plan for 6 months, the addition of continuous oxygen has been the difference between a slow downward spiral and a clear path back to closure. Let me also explain what the experience is like for the patient at home. The device itself is small enough to wear under loose clothing. Most systems weigh under a pound. The oxygen reservoir is refilled or swapped at the wound care center on a regular schedule. The dressing is checked and changed by a nurse, by a family member trained at the clinic, or by the patient themselves, depending on the wound location and the comfort level. There is no chamber to enter. There is no pure oxygen environment. The therapy fits around the patient's day, not the other way around. That single change, treatment that fits around the patient instead of the patient fitting around the treatment, is what made the trial completion rates so different from older oxygen therapies. When patients can finish the prescribed course gets to do its job. When patients drop out at week 4 because the chamber appointments are too disruptive, the prescribed course never finishes. Continuous oxygen gel solves the adherence problem first, and the biology problem second. Now, I know what some of you are thinking. If this is real, why has my doctor never mentioned it? You are right to question this. The honest answer is that the technology has arrived faster than the guidelines and faster than the insurance reimbursement landscape. Continuous oxygen gel systems are real. They are FDA cleared in the United States. They are covered by Medicare and many private insurers when prescribed for the right indications. But many primary care doctors and even some podiatrists have not been trained to think of it as a first-line addition. The wound care community knows about it. The cardiology and primary care worlds are catching up. Who does this not help? It is not a magic eraser. Patients with significant peripheral arterial disease, where the artery itself is too narrowed to carry blood to the wound, need vascular surgery first. Patients with active deep infection that has reached the bone need antibiotics and possibly surgical drainage first. Patients whose diabetes is wildly uncontrolled need their blood sugar addressed first. Continuous oxygen gel does not replace the foundations of wound care. It accelerates them. Here is how that played out for Frances. After 6 months of stalled standard care, we did not throw out anything she had been doing. We kept the dressing changes. We kept the offloading boot. We kept the antibiotic course. We added continuous oxygen gel on top. Within 4 weeks, the wound had shrunk noticeably. Within 12 weeks, it had closed. She had been 3 weeks away from a conversation about partial amputation when she walked in. She is now back to gardening with her granddaughters on Saturdays. That is the entire promise of this technology. Not a miracle, an accelerator on top of a foundation that was already correct. So here is exactly what I want you to do, starting tonight. Tonight, take a careful look at any wound on your feet, your shins, or your hands that has been open for more than 4 weeks. Take a clear photograph of it under good lighting. Date it. Place a coin or a ruler beside it for scale. That photograph is the most important page in your medical file you will ever produce on your own. This week, call your primary care doctor or your podiatrist and ask one specific question. Is my wound a candidate for continuous topical oxygen therapy? Some of you are going to be told no, and that no will sting. I want you to take that no seriously, but not as the final word. If your doctor says you are not a candidate today, the next 2 questions matter more than the no itself. Question 1. What would have to change for me to become a candidate? Question 2. How often should we reevaluate? Most patients who were turned down at month 2 of a stalled wound are good candidates by month 4 if their blood sugar control is tightened, their offloading is verified, or their vascular workup is updated. The path is rarely closed forever. It is usually closed until something else moves first. If they say yes, ask for a referral to a wound care center that offers it. If they say no, ask why specifically: deep infection, vascular insufficiency, blood sugar control, or some other reason. Each of those answers points to a next step. If you do not have a wound right now, share this video with someone in your life over 60 who does. The number of seniors with a quietly slow-healing diabetic wound is much higher than most people realize. You might never know it, but you could be the reason someone you love keeps both feet for the next 20 years. Continuous oxygen therapy is one of the few additions to diabetic wound care in 20 years that is changing outcomes meaningfully. Most patients still have not been told it exists. The conversation needs to happen. Next, I am going to walk you through the new LDL cholesterol target of 55 and why the limit your doctor has been working with for years may have been quietly outdated. Stay close. Take care of your feet tonight. If you have a wound that has not been closing, please do not wait another month. I am Dr. Richard James, and I am rooting for you every single step of the way.